they work together properly, and it's a harmonious functioning of all the effective parts, which does sound a whole lot like collaboration, which is to work jointly with others, especially in an intellectual endeavor, and to cooperate with an agency or instrumentality with which one is not immediately connected. So I feel like they're kind of on the same spectrum, where coordination is a little bit less connected than collaboration, but they're pretty close to the same thing. We love technology. My sincere apologies. We are working on slides. More? Sorry, Jamie. So when you apply it to integrated healthcare, care coordination can be defined by the Agency for Healthcare Research and Quality's deliberately organizing patient care activities, sharing information among all of the parties concerned, knowing the patient's needs and preferences ahead of time, communicating them to the right people at the right time, and actually using that information to provide safe, appropriate, and effective care. Collaborative care, which I don't normally reference Wikipedia because it's Wikipedia, but I thought for purposes of this I was going to, because I really wanted to find a generic definition of it, which they define as a healthcare philosophy that has many names and many models, and usually includes the provision of mental health, behavioral health, and substance use services within primary care. Sorry. Common derivatives, and you can click one more time, because there's a whole lot of names for it. But usually when you see anything in the literature, collaborative care refers to the collaborative care model. So care coordination approaches would include teamwork, care management, medication management, health information technology, and or patient-centered medical home. The activities would be everything from establishing accountability and agreeing on who's responsible for what tasks, actually communicating and sharing knowledge pretty freely, helping in transitions of care, assessing patient and family needs and goals, creating a proactive care plan with patients and families, anything from monitoring to follow-up to responding and changing needs to providing self-support management, linking to the community and aligning resources. So it's a wide variety of activities, and care coordination could almost mean anything that you're doing to try to connect patients and families with the system in a broader way. Versus the collaborative care model, which is an actual specific model for integrating mental health services into primary care that is very, very research-based. So the University of Washington created a number of years ago the impact model, and since then they've changed the language to collaborative care model because they're starting to see that this is more than just one standard way of doing things if you have some of the core elements. So they did a ton of studies in looking at how using this model is able to help primary care providers better treat depression in their settings without needing to pull in a lot of extra psychiatry time. So the model to this day retains the approach of having a person or patient-centered medical home type of a style with a physician at the center who's providing primary care. A care management staff, which would include a behavioral health specialist, nursing staff, all of the clinic staff, potentially medical assistants or nurse practitioners, so whoever is working within the primary care setting that is managing the care of this patient population. A behavioral health specialist, which depending on where you are will vary. That could be social work, counseling, psychology, but anybody who's very comfortable working with individuals with mental health conditions. And a psychiatric consultant, which is either live or via telemedicine. Because the point of the model is to use the behavioral health specialist in the primary care setting to help treat the depression, and use the psychiatric consultant to help teach and guide the primary care physician on medication practices. The collaborative care model is team-based, and they want care coordination and care management. So what part of that means is that they do regular proactive screening and monitoring. They do really universal screening. So things like a PHQ-9, if you're doing universal screening for depression, Things like a generalized anxiety, the GADS, generalized anxiety disorder scale, if you're universally screening for anxiety. So really any validated assessment could be used for universal screening. But they also do monitoring. So over time, people are routinely screened again. If they're doing a PHQ-9, then they redo the PHQ-9 every visit or every month or on some type of set schedule. And they do treatment to target. So the goal is to get the numbers on those assessments down to what would be considered non-risk or low depression or low anxiety. And if those individuals are not improving, especially over time, using that consultation from the psychiatric provider to figure out either what we need to change, what we need to do, or eventually do we need to send this person for psychiatry because they're too complex to be treated in a primary care setting. This is one of my favorite quotes, so I use it as routinely as I can, because when I think about coordinated care and collaborative care or any type of integrated care, what I always feel like it boils down to is teamwork. And Atul Gawande had this awesome article called Cowboys and Pit Crews, where he talked about the world of doctors being the cowboy and having to be able to do it all and be everything to everyone is way far over. We don't need cowboys in healthcare. We need pit crews, because pit crews can run completely efficiently and they're able to support each other, and everybody has a role, everybody has a responsibility, and they work like clockwork, and it's very effective. And effective teamwork is the practical response to recognizing that each of us is imperfect, and no matter who you are, how experienced, how smart, alone, you'll fail. So then I found an interesting article, and I kind of wanted to have a little bit of dialogue about this before we get into the case, because it was an interesting thing in the New York Times about the tangle of coordinated healthcare and how, as we talk about care coordination and we get managed care involved in Ohio, and the more people you get involved, the more you have case managers, care coordinators, patient navigators, health coaches, community health workers, possibly peer recovery supports. The list goes on. And really, how do we make sure that all of those people are talking, and how do we make sure we're talking to the right portions of those people? And I think that's where it can get kind of complicated. So what do you guys think? I mean, I'm sure you've seen this, and I'm curious what anybody else thinks about this kind of mess of people who should be talking.
I mean, I think it's difficult to achieve. I mean, even the case I presented last week, there are so many people involved, and even trying to reach out and then waiting to hear back, and a lot of like missed calls, and you're seeing other patients when they call back. It's very difficult, I think, to coordinate and keep everyone in the loop as far as how the patient is doing. Mm-hmm. It requires a lot of like outside work, like outside your normal clinical time, I feel like.
I agree. I think that one of the hard parts, is there's a lot of potentially lost billable or quote unquote productive time when you're going around trying to contact other providers who have interfaced with your particular patient. Though on the other hand, of course, when those relationships are strong and you have some sort of mechanism to where you're talking regularly about patients, it can obviously really improve things. I've been in situations where things weren't going well, and let's say a particular patient is interacting with a psychiatrist and a primary care physician, and getting different messages from those two providers, and then are quite confused about how to proceed. So I think that's sort of really where things can go wrong, and why it is important to try the best you can to reach out to folks and make those connections. And what I found helpful is if you can almost on a macro level set aside time to where if you're interfacing with a particular agency or particular provider, there's a set time where you can sort of interact about your shared cases. I'm wondering, those of you who are all in the field, what have you found in terms of this scenario?
Jody?
I was going to say, for me, just being a newbie at a lot of this, of actually being in the behavioral health care arena, I'm finding that it's so important for the patient themselves or your client to know exactly who is on the team and what the role of each person on the team is, because when I have the patients come to me, and so many times they don't really even know who is on the team and who's really acting in their behalf. So knowing the roles of everybody on the team. And I love how you said, Nicole, about talking to the team, but also talking to the right part of the person who you're talking to. So you're not going to go and spending a whole lot of time, if you know you're going to the doctor and you're going to spend a lot of time talking about something the dietitian is going to cover. So knowing exactly what it is that you want to talk about with each individual person on that team.
Very good, thank you. Any other